Okay, well, let's go ahead and get started. Welcome, everyone. My name is Allison Fiscalini. I'm the director of the Athena Breast Health Network and Wisdom Study based at UC San Francisco. And thank you for joining us today for a discussion around ending the confusion with precision breast cancer screening, moving from debate to wisdom. So just as a couple of updates for today for everyone to know, this meeting, we'll have all the microphones muted, but we encourage everyone to please use the Q&A function at the bottom of your screen of the webinar to submit questions, and we'll have time at the end of the meeting to answer those questions. I will also be monitoring those questions throughout, so can send answers to those questions as the discussion is going. The meeting is also being recorded and it'll be posted to our YouTube channel afterwards as a resource for people who either weren't able to join or if you'd like to listen to it again or share it with people that you know. And then we will be sending you an email with a short post-meeting survey to get your feedback. So we look forward to having you join the conversation and getting started. So the agenda for today's webinar is an introduction by Marcela Gaitan. We'll then have some background on breast cancer by Dr. Laura Esserman and an overview of the Wisdom Study by Celia Kaplan. And then we'll have time at the end for Q&A. So with that, I will pass it off to Marcela and we'll get started.
Okay, hello everyone. Good afternoon and good morning, because I know there are some people, I'm in the East Coast, so for me it's afternoon, but I know for the people of the West Coast, it will be morning. My name is Marcela Gaitan and I work with the National Alliance for Hispanic Health. We are implementing the Nuestras Voces, our Voices Network program, and we're very pleased to partner with the Wisdom Study program to provide this webinar learning opportunity for our colleagues around the country. Next slide, please. The Alliance is a nonprofit public health organization. We're based in Washington, D.C., and our mission is best health for all. We work to ensure that health is based on what we know about people, the science, and culture. We are the largest in all this Hispanic network of community-based organizations that provide services to over 50 million people around the country. We believe in community-based solutions, and we do not take any funds from alcohol, tobacco, or sugar-sweetened beverage companies. Next slide, please. The Nuestras Voces Network is one of the, is part of the CDC consortium of national networks implementing public health strategies. And these are oriented to the prevention of commercial tobacco use in cancer prevention in priority populations. And the focus on Nuestras Voces is to provide, is working on collaborations in expand multi-sector networks to address the impact of commercial tobacco use and reduce tobacco-related cancers, in particular in Hispanic populations. Next slide. And now we'd like to introduce our speakers for today. We have Dr. Laura Esserman, who is the director of the Carol Frank Buck Breast Cancer Center at UCSF. She's also the founder of the University of California's White Athena Breast Health Network, and then is also the PI for the Wisdom Study. And she also somehow finds time to be a singer, a songwriter, and a theater performer. I would like to see that sometime, Dr. Esserman. The next speaker is Dr. Celia Kaplan, and she is a professor of the Department of Medicine at UCSF. She's also the director of a community core of the Center for Aging in Diverse Communities, and she's the member of the Medical Effectiveness Research Center. And the research focus for her area of focus is actually on health disparities among underserved U.S. minority populations, with a particular emphasis on Hispanic Latino health. And Dr. Esserman will give you now the podium.
Well, gracias, thank you. And estoy alegre para hablar sobre wisdom contigo. So next slide, I'm well aware how confused people are about screening. This is an issue because when people are confused and think the experts disagree, many times what they decide is just not to even get screened. And screening is complicated. We've really issued a very simple message that everyone should get screened and everyone should get screening every year. And that's a simple message. And I think there are a lot of things that misses. And I think the opportunity is for us to really think, since we've been doing it the same way for 30 years, yet our science has really changed so much, it's time for us to rethink this and bring the community in with us to help us learn and make the right changes and help everyone do better. Next slide. So there are many guidelines for screening. Some recommend every other year, some recommend every year, some recommend screening at 50, some recommend screening at 40. We can look and see, how many people have had screening in the last 2 years. And you can see actually that the lowest conformance to, the people who use the fewest mammograms really is the Hispanic population. And this is not necessarily a good thing. It used to be that African-American women really had much lower rates of screening, but in the recent past, this has changed. And as well, Black women used to have fewer cancer diagnoses, but now the rates have probably gotten to be the same. That's really one of the unintended consequences of screening, is that when you screen, you can not only find consequential or serious cancers, you can also find small inconsequential cancers. And that again can be one of the complications of screening. So that's just something we need to keep in mind. But this complexity actually can be incorporated into a better approach for everyone. Next slide. And we're going to talk a little bit about that. We know that there are several barriers to screening. People don't want to get screening if they don't have health insurance. We're very lucky in California that we have a statewide program that actually helps people with screening costs. But it's very important that if you get screened, one of the things that can happen is that you could get recalled, and if you just have coverage for screening, that doesn't help you with the workup. So there are definitely concerns about costs. There are also concerns about whether you have sick leave or you're able to miss work, because if you come in and get extra images, that's a hassle. You may not have access to a high quality screening center. You might not have transportation, or your providers may not be pushing you to get screening, or you might have different messages from your different providers. And there are, individual and cultural concerns. Some people may know a lot about it, some people may know little about it. I think that a lot of people don't really know the issue about breast cancer risk. We've now learned that breast cancer is not the same disease, it's actually many diseases. And certainly we know a lot more about risk. So why aren't we thinking about trying to screen everybody according to their risk? This is a real important effort for us to educate the community that we want to bring the changes in science and bring it forward to give better options. And and it may depend on whether you've got childcare, or how recently you came to the US, language differences, those kinds of things. And then just health concerns. Some people are afraid to go in and get screened because they don't want to hear bad news, or they're worried that they might be asked to get a biopsy. One of the things that's very concerning is if people have been called in to get a biopsy once or twice, they may just not go back. That there's a 50% chance that people just don't go back after that. And I think that's something that we have to think about is, people are so anxious not to miss a cancer that their threshold for recommending a biopsy sometimes is too low, thinking that people would rather know, but it's uncomfortable and scary to get a biopsy. So I think these are all things that we need to work on to make screening better. And that's really the purpose of the Wisdom study. Next slide. So who gets breast cancer? Does everybody have the same risk? Well, certainly not, because your risk depends on your family history. It depends on genetics. These are the genes that you inherit, that's just part of everybody. That's true for diabetes, it's true for heart disease. So of course it's true for cancer, and breast cancer in particular. How dense your breast tissue is impacts your risk. Your age impacts your risk, and your age impacts your risk of getting different types of cancer. Your race impacts and ethnicity impacts your risk. African-American women have more risk when they're early, when they're young, for a more aggressive type of cancer. But we actually haven't quite learned how to screen for that yet. That again is one of the big goals for us. It's not that it's that common, but if we knew better who was at that risk, we would screen more frequently. We would probably screen earlier. So this is why it's so important that we understand, you know, I think that's probably also true for the Hispanic population. So it is really important for us when we do any kind of screening study that we not just have it be white women. It is so, so important that it include the whole community. And if all of you want these studies to reflect your needs and your interests, it's essential that you be part of it. There's otherwise nothing we can do to make it better. And, you know, lifestyle and exposure, like when you had your children, how often you breastfed, whether you take hormone replacement therapy, you know, these things are all important. So these are the things that we're trying to study. Next slide. So this is, again, what I was trying to say is it turns out that, you know, the incidence rates are now about the same in white women and African-American women. They're lower in women who are Hispanic or of American Indian or Asian descent. And the death rates are a little bit lower too, but you can see one of the concerns we have is that women who are African-American still have a higher risk of dying. Now you could say that's about access and that's all about social factors, but it's not. It actually for sure is about biology, because there is some people who are more at risk for these aggressive cancers. It is absolutely essential that we start to figure that out. And that's what a group of us, my colleague, Dr. Olopade, who's Nigerian, and she's at the University of Chicago. So this has been her life's work. There's a number of people who are really, the Sisters Network, there's a bunch of people who are really trying to make sure that we get this in, and we're trying to change the way it's been, where a lot of the big studies really reflect risk based on African ancestry, European ancestry. That's just simply not good enough. So we want this, it's our goal for Wisdom to make this every woman study and have it reflect the population in the United States. So that's why we're reaching out to you to make sure you're aware. And if you haven't had breast cancer, to make sure that everybody joins the study and that you tell everybody you know to join the study. Next slide. And Celia is going to tell you how easy that's going to be. So, you know, again, we pretty much already, talked about this. And again, the issue about I think the why we're concerned is that among women who are younger than 40, Black women have higher rates of breast cancer. And that's because this hormone negative, or what we call triple negative breast cancer, is more common in younger women, and it's more common in African American women. So that's why if we knew about it, and we knew that small group of people who had it, we could screen them more frequently. So, and if you think about it, in Latina and Hispanic women, you know, breast cancer is the leading cause of cancer death, and probably because the smoking rates are lower. So lung cancer isn't as much of an issue. So these are really important, and it's really important for the community to understand this and join with us to try and figure out, you know, how we can do better. Next slide. So our big message is that one size doesn't fit all. Not for polar bears. Perhaps I'd have a brown bear on there too. But maybe the cub can get in there, but the big bear can't. So we've got to do better. Next slide. So we're really in an unprecedented time now. We know so much more about cancer prevention. We know a ton more about risk assessment. The Affordable Care Act is safely ensconced, you know, and that means that gives you protection about knowing about your genetics. And instead of being afraid of understanding what genes you inherit, what we want to know is make that powerful so that we can know, you know, most people will not be at high risk because of the genetics. The vast majority of people will be at lower risk. So that's good. But for the small people who are, it's not a bad thing, because there's something we can do about it. We can do better for prevention, and we can do, or what we call cancer interception, help you try and make sure that you don't get it, and to also see if we can find it. And there's been advances in technology. So it used to be super hard to do the kind of genetic screening or look, you know, now if you spit into a tube, a tube that arrives, you know, in a package in your house, and you put it back in the mail, you spit in it, that's it. All of a sudden, we can actually tell you more about this. And, you know, again, it's very private and you don't have to share it, but it's information, and knowledge is power. Knowledge is power to help you take better care of yourself. Next slide. So this is why we put this wisdom study together. The reason we call it wisdom is we want, the only way to do better is to know better, as Maya Angelou would say. And it is about women being informed to screen depending on measures of risk. And we are testing the one size fits all annual screening and comparing it to personalized screening, meaning that we're going to assign you when to start, how often to screen, when to stop, based on what your individual risk is. Next slide. And this is how we're going to make it better. We're doing this very large scale trial. We already have 33,000 women in the trial already. We want you to join and be one of the 100,000 women being part of the study. It's your study. It's about you. It's about making things better for your mother, your sister, your daughter, your friends, and you, really. So and the only way to do that is a big, large scale trial where we're all part of it. The Women's Health Study really revolutionized our understanding of whether it was safe to use hormone replacement and in whom. This is another one of those studies that can really launch us in the right direction to say, you know, that we can really sort out whether a personalized approach to screening is just as safe. And it's essential, as I said, that everyone from all backgrounds participates, and we can test this new approach. And within this, there is the opportunity for breast health education and prevention. It's not just about screening. If you're at risk for cancer, and as we start to understand better how to prevent that kind of cancer, that's what we do. You know, again, people know about taking statins for reducing the risk of heart disease or lowering their blood pressure, and so they know that's important for their health. We're trying to get breast cancer on that same trajectory, and we can if all of us work, and we are committed to having a diverse population of women to learn about their own risk, so we can help develop improved screening and prevention for future generations. Next slide. So how does all of this work? Keep going. The whole idea is a personalized approach. So what do we mean by that? We want to know about your breast density. And, you know, if you have a mammogram, we want to be able to share it, get a hold of that mammogram. And if you're in the personalized arm, you know, we just send a little kit to your house, you spit in it, send it back, and we get that information back. We ask you some questions about your lifestyle and, you know, when you had kids, when you got your period, those kinds of things that help us. That these are things that we already know do influence your risk. Next slide. And so what are our questions? We want to know, is a personalized approach just as safe? Is it just as good at avoiding high-risk cancers? And we hope in the future it's going to be better. Does it reduce the chance that you'll be called back for what turns out to be nothing? If you screen less and your risk is lower, that should turn out to be so. Next slide. But again, we don't want to do less for the people with more risk. We want to do more for the people with more risk and less for the people at lower risk. And prevention, will people knowing about their risk make it more likely that those people will be motivated to say, oh, I didn't realize it was a risk for this, and, you know, can I go forward? Next slide. And is it accepted? You know, if we tell people that you don't have to screen every year and you can come back every 2 years because we know your risk, are they going to be comfortable with that? Or, you know, or is it like 20 or 30 years of health messaging that everyone has to come in every year is so important that they can't get over it? That's one of the things that we're testing. We hope that's not true. And we are actually looking to you to help us with those messages to make sure at the end of the day, we're trying to come up with something that creates more value. So better overall outcomes at lower cost to the individual and to society, right? We'd like to put our resources to the people who have the higher risk and then have have fewer complications and pain associated with things that really aren't going to add too much. So that's really what we mean by value. So next slide. So I'm going to turn this over now to Celia, who's going to tell you a little bit more about the nuts and bolts of how you can be part of the 100,000 women helping us, you know, change the world and change the future for you and your daughters and your mothers. And so we can really lower the risk of this really dreaded disease.
Thank you, Laura, for the transition. Anyways, I am very, my name is Celia Kaplan, and I have been in Wisdom since it started. And it has been a privilege because I do strongly believe that wisdom study is a partnership between researchers, clinicians, the community, and patients. The next one, please. It is also one of the things I really love about this study, and I'm a fan of it, is that it is actually designed, it's not only the goals to improve healthcare and better breast cancer screening for all women, but it was designed with an eye to involve everybody, to make it accessible for everybody. And it actually is perfect in the time of COVID because everything is being done online. It's a study that was designed for people to do it from their home, online, not to have to visit the doctor's office for enrollment. Can be done on your personal computer, on your tablet, on your phone. So that is, I think, something that makes it accessible to everybody. This is our website, wisdomstudy.org, and you'll see it several times. So write it down, and so you have it accessible and you can check us out. All the services are rendered virtually, and what we have is the ability that if somebody's at high risk and he has questions, they can consult with the breast health specialist through telehealth. As I said, there are no additional visits. We give some information back to the participants once you select your group, and we'll go further into that because that's also an innovative aspect of this study. We give you what we call your screening assignments, our recommendations for you to do it. And I want to assure everybody that our study is confidential. We all know that we all are very concerned our personal health information that is not being shared with other organizations. We want to assure you that everything has been designed with an eye on confidentiality and nobody can identify an individual participant. Next, please. So now let's see who can participate. Women from 40 to 74, women that never had breast cancer or ductal carcinoma in situ, that is also called DCIS, and people know it by that. And we have all our materials in English and Spanish. So I know that many of you work with monolingual Spanish speakers. So we are prepared to help out everybody to participate in the recruitment. Next, please. Now, how to enroll? And again, everything has been done online. We just have revamped our website to make it more accessible and easy. So a participant creates a private and secure account, and all the communications that you guys are going to get is through this account. We have to confirm eligibility, and that are few questions. Of course, like in any study, there's a consent form to sign, but we sign with DocuSign. Everything has been established so that you could read it, print it, look at it, and sign. And there are study surveys. But next slide, please. But this is what I think is one of the most innovative aspects of this study. In most studies, when you go to a clinical trial, the computer selects your group. And of course, we offer these possibilities, and that is called randomization. And as researchers, this is the highest scientific level in order to find out differences. But there are many questions that we want to answer, and everybody can participate. So you can also self-select your group. So we give you the option, A, do you want to be randomized? And the computer will do that for you. And B, do you want to self-select your group so you are comfortable with the assignments you get? And the two groups, as Dr. Esserman indicated, is the personalized screening or the annual screening. And if you have more questions about either the procedures or what goes into each group, please make sure in your Q&A you write it down and we'll answer them later. Next, please. So we also give you what I mentioned before is the screening report. And so does it say in the screening report? The age to start or stop screening, how frequently you need to do it based on your characteristics, the type of screening modality, and there are several: mammography, ultrasound, MRI, and additional risk reduction strategies. Next slide. Next one, please. And we want to, so these are all our organizations that are participant. Of course, we have all the UCs, and there are different organizations all over the country, University of Chicago, Louisiana, etc. But irrespective of that, anybody can participate, and wherever you are, in whatever state you are, we will assign a coordinator that will help you answering your questions and help you through the process. By the way, each of these organizations has gone to the Human Subjects Review Committee, so to make sure that you are comfortable that the strictest criteria of human subject protections have been followed. Next one, please. That's our enrollment, 100,000 women. We are getting there, but we need the help of everybody. There are many ways that one can help. Next, please. Oh, this is sort of to assure you that all our materials are in Spanish. And we really try very hard that the language is accessible to everybody. We try to use the simple language, but we also have a phone line and an email that people can call us if things are not clear to them. Next slide, please. So here is how can you help? And I know that many of you are part of organizations through the CDC and other ones. So here are things you could do. We also know that in the audience are participants, and we cannot thank you enough for your participation in our study. And by the way, you are one of our greatest advocates. In terms of recruitment, you have helped us with your family and friends calls in increasing our recruitment substantially. If you haven't joined us, go and check us out. Go to wisdomstudy.org. We have some more questions and answers for you if you want more information. You could also route people to go there. And if you're interested, please join us in finding the answers. Some women in the audience and some women in your circles are not eligible. Many women with breast cancer want to participate, but unfortunately, at this particular point, we are only recruiting women that have not experienced breast cancer, but they can help us. And the way they have done it in the past is by sharing the information with their family and friends, their daughters, and many of them may be at high risk and might benefit from participating in the study. Next, please. So there are other ways that we participate. We have we have Facebook, Twitter, Instagram, LinkedIn, and we do postings. So please check our postings. But also, we have done other things. People have sent their posts to their groups, and that has helped us enormously in our recruitment. If you are part of an organization, if you can post our postings, that also will help us the same way that Marcela has helped us incredibly in the recruitment through the postings. We have wisdom activities. We have talks, we have webinars to our participants. We send our newsletter with useful information. Please connect us to your networks, and we're more than happy to join you in webinars or small talks to where we can explain to your audience more in detail, ask questions. And in general, what we are asking you to become one of our ambassadors to spread the word about what wisdom is all about. Next, please. This is Wisdom Study. It's pretty much Wisdom Study, or in LinkedIn is the Wisdom Study. So join us and follow us. Next slide, please. So we want to introduce you two of our coordinators. Marcelo Palmieri, who's bilingual and bicultural Spanish speaker. He helps everybody that is a Spanish speaker and may have some difficulties maybe with questions, and he kind of guides them to the system if they get into difficulties. And Tommy, since we're UCSF, is helping everybody that is coming through our network. But we have coordinators in each of our sites, and we will assign you one and they will help you out. Next, please. So this is our last slide. This is the information where you can contact us, and we highlighted our website and our email. The wisdomstudy.org is our wisdom study, and our email. We thank everybody that participate. Don't leave. We're going to have questions and answers. Usually that's where a lot of the interesting information comes up. So stay for it. And we are sending you the post-webinar survey. But before we go, I want to thank all the participants in our study that are part of the audience, and a special thanks to Marcela Gaitan for helping us coordinate. She has been wonderful in helping us out in our study. So thanks again, and I hope our partnerships continue. I don't know, remember who coordinates the Q&A. I leave it to that person. I don't know if it's Marcela or Allison.
Yes, I can read the questions, and then Allison, I think, will be able to answer some of them. Let me just think. I think she already been working on a couple of questions, providing it was questions related to this. This information was available in Spanish, and yes, it is. And I actually have a question about that. When you provide, Celia, you mentioned that you guys provide health education and prevention to the participants. Now, is that part of the study also provided in Spanish when you do telehealth sessions? Can they also do it in Spanish?
I might leave to Allison because she's the project director and she knows exactly how that happens. Allison?
Yes, so the tool itself, the breast health decisions tool, has been translated in Spanish, and then our breast health specialists, if they don't speak Spanish, we have a translation service available that similar to if you're getting a regular medical appointment, would be a translation or a translator who then joins the call with you to translate the information from the breast health specialist.
Okay.
Yeah.
So let me just go to the questions right now. The first question, I had numerous mammograms with a finding of hyperdense tissue. My PCP is test averse. I am aware of recommendations for ultrasound as a follow-up to dense tissue. Please discuss.
Yeah, so this is I think this is exactly the reason why we're interested in a study like Wisdom. The way the guidelines are written, they say that women should be informed if their breast tissue is very dense. And that's actually not terribly helpful because it just makes everyone kind of anxious, but they don't really give good guidance about what you should do. And part of the reason they don't give good guidance is because we don't know the best thing to do. Ultrasound is not really a great screening tool. And even though it's used very frequently by people, it's not. It has a lot of false positives and it's not great. If you, that's one of the reasons why our approach is, if, you know, breast density is one of the things that contributes to your risk, but it's not the only thing. So if you have dense breast tissue and you have no other risk factors, you may not be in that high risk study group. If you are, and you're really at a high risk, the better tool for you to be using would be MRI. But we don't want to use MRI unless your risk is, you know, significantly elevated, because again, all these tests have false positives. So what does that mean? That means when you get the test, they find things, but those things that they find don't turn out to be cancer. But that experience of going through that extra screening and finding things and going through biopsy can be alarming and anxiety provoking. So we're trying to be smarter about how we use these tests. So for someone who's truly at high risk, MRI is the better study. If you are in the middle and you're, you know, you may need to be studied more. And we again need to do better and find tests that work better in the very highest risk women. That's something that we're also starting to do from the wisdom studies. We're starting to develop, you know, tools that might be, you know, modifications of MRIs that have, you know, a lower chance of false positives, that are faster, that are not so difficult for people to go through. So that's one of the things that we're working on providing for the women who are in that group who have very dense breast tissue. So it's a work in progress. If you're recommended to have an ultrasound, you can do it, but just be aware, just because they find things doesn't mean that that's likely to be a cancer. One of the reasons why ultrasound isn't as good in very dense breast tissue is that both mammograms and ultrasound work by looking for the difference between how dense a cancer is and how dense your breast tissue is. So that's the radiation ions, the beams, the photons that go through the breast. They're looking for that difference. And ultrasound is using sound waves again to look for the difference between how a dense tumor might be. And if the tumor density is the same as the breast, it's not going to work as well. MRI works completely differently. You get an IV and you get a dose of a very bland inert substance called gadolinium, and that's taken up by the vessels, and so that can light up. So we call that a contrast study. So that's why we think that, you know, if your risk is truly higher, you should be getting a different kind of study. Again, that's all baked into the wisdom study and why we're trying to run this program.
Okay, thank you, Dr. Esserman. The next question has to do with recruitment of Black women for the trial, and if you are doing any particular efforts to recruit women, Black women, and also if you have any breakdown in terms of the age group of those Black women who are participating, and then if you have any Black advocates serving as wisdom team members.
Alison, you want to start with that?
In terms of the numbers, I don't have that on hand, but I'm happy to follow up and provide that after this call. We do have Black advocates on the study who are part of the advisory committee. We've recently also formed a community leadership board, and that represents you know, all race, ethnicities, and community leaders who can help us to not only develop our messaging, our approaches, but really be able to weigh in on strategies and make connections for the study team into the community, build those partnerships, and really build that trust in order to share the information and have it come from a trusted source. So the community leadership board, as I mentioned, we have subcommittees focused on different communities of color, and we are working to expand the work that we're doing within the community. During this time of COVID, it's a little difficult because there isn't any face-to-face interaction. And so we've been trying to figure out how we can still reach people in the absence of community gatherings, events, you know, so social media, other ways in which people are communicating is an area we've been focusing on, at least in the last year.
Yeah, I would say, so Dolores Moorhead is one of the leaders in the African-American community, and she has been a vocal advocate for this study. And as well, one of our community board members is, you know, part of the leadership of the Black sororities, and we're actually getting organized to put a presentation together for them as well. And if any of you out there have ideas for who would be interested and who we should talk to, that would be great. One of my colleagues at the Breast Care Center, Cheryl Ewing, is African-American, and she's been a very vocal advocate for the study. She's also in the study. We have lots of, you know, leadership of people who are either in the study or wanting to promote it. What we're looking for is ideas for who you think would be interested, and that would be fantastic if you give us some suggestions. And, you know, we're happy to do a seminar like this, specifically focused on the African-American community. Fumi Alapade is an oncologist at the University of Chicago and a long-term colleague and friend of mine who I've been working with for 20 years and who's dedicated her life to really understanding the genetic predictors for risk of aggressive cancers and really looking at the difference between African women, African American women, and the average, other women in the United States. So it's a really important focus for us. Yeah, so thanks for that question.
Okay, the next question is, my mother had breast cancer at age 69 in her right breast and again at 85 in her left breast. However, when answering the questions in your doctor's office, the question often asks if the cancer was detected before age 50. I feel as if your loved one was diagnosed after age 50, they give less attention to your concern of breast concern when you have passed 60 years of age. Please speak on why this question is noted for a person that already passed the age of 50.
That's a great
Any
question.
comments on that?
Yeah, that's a great question. And that it's interesting, we know why we ask that. And it's interesting to know that people find that annoying or confusing. The reason we ask about before age 50 is the people who have inherited an error in one of the genes that really affects your risk of breast cancer. For example, BRCA1 or 2. The kind of hallmark of that is early breast cancer. If you've inherited BRCA1, BRCA2, PALB2, there's about 9 genes. And again, this represents maybe 1 to 2% of the population. But if you have that, the hallmark of that is early onset cancer. These often are more aggressive. And starting your screening at 40 or 50 will not help you because these are early onset. So I think people are just trying to flag if you had relatives who had breast cancer at 25 or 30 or 35, these are kind of red flags for us to make sure that that we think about it and find out, could you be from one of these families that really has one of the syndromes for cancer? But in truth, the vast majority of breast cancer risk is different, and it's more like what you described, someone at 69 and someone at 85. Now, these kinds of cancers, not only is that important for understanding what your risk is, but it is very likely that this kind of cancer is the very kind of cancer we're good at preventing. So if you have higher risk for these kinds of cancers that are older onset, hormone positive, that's exactly what some of the prevention, or what we call cancer interception, is all about. That some of the medicines like tamoxifen or aromatase inhibitor, some of these medicines that actually reduce the chance that you would get that disease, get cancer later in life, are really important, and they can be given even when you're 45 or 40, and that can influence your risk or decrease your risk for 2 decades to come. So that's another reason why we want to know the difference. We want to know if you have history and if that history was young age. By default, if it wasn't young age, we know it's older age. So we're actually asking both questions, but we're just doing it in one question. But one thing that might actually be helpful to us is to actually put a little learn more button. So when we're asking the questions, have a little bit of information, and if people want to know, why are you asking that question and what are we doing with it? It's interesting. I'm so glad you asked that question. It really helps me to understand what people might be interested in knowing, and that's a way we can make our study better.
Okay, the next question, under personalized screening, what are some of the options that may be recommended? Some examples, please.
So if you have a high risk, so let's just say your risk is pretty low and you're 43, we might say, well, don't bother to come back and screen until you're 50. But if you're 43 and your risk is high, we would say, okay, come in and screen. And you might be told, because if it's very high, you might be screened every 6 months. That's in the highest risk group. That's pretty unusual. But if your risk is super high, we might do that. Or we might say screen every year, or we might say screen every other year, or we might say come at 50 and then start screening every other year. Those are the kinds of things that we can say you might like join at 55 and think that you're low risk, but turn out to be high risk. It turns out that most people overestimate their risk. So a lot of people who think they're higher risk really are not. And again, if you have questions, you can always ask to talk to the breast health specialist and they can go through it. And, you know, one of the things that we're trying to study is, are people willing to follow the recommendations that we give? If, you know, so if in your mind, you thought you were high risk and we tell you you're not, is that just confusing? Are you willing to follow it or not? What we hope is that people will reach out and let us talk to you about it and help guide and counsel you. And that helps us do a better job of explaining the information we have at hand and understanding your concerns. Celia, do you want to answer, you know, follow up on that at all? You're on mute.
Oh, you're good.
Oh, thank you. No, I think you summarized very good. And I think that we don't think sometimes that, hey, we don't need to go every year. And if somebody is at low risk, that's a great thing. And if you are at higher risk, and for somebody that was at high risk when wisdom did not existed, I wish I would have had a way to find out and screen more often at an earlier age.
Right. And even though a lot of, you know, there's also what we find is the primary care physicians, you know, say, oh, well, then maybe we should just start screening every year starting at 50. And the radiologists say, well, why don't you just screen every year starting at 40? And the women get caught in between. They'll often get, you know, conflicting recommendations from different providers. And, you know, we don't think one size for everyone fits everyone anyway. So we think this is a better way forward. So we, you know, the faster everyone gets onto this kind of a trial, the sooner we'll be able to, you know, show that this is, you know, we hope this will be a better way forward. We wouldn't study it if, you know, people didn't think this wasn't likely to work, we wouldn't study it, but I think we have to prove it. Oh, and by the way, just to remind people, again, I want to make sure that people do understand that, you know, if you really you're like, well, I don't know what's the best way to do it, you know, it's great to be randomized. But if you really have a strong feeling, well, I want to be screened every year, no matter what, then you should choose that arm. And if you say, well, look, I really just want the personalized arm, I want the information to be told and I'll follow what the recommendations based on my risk, then choose the personalized arm. So there's something for everyone. So everyone should be able to join.
Okay, the next question has to do with the resources for answering personal questions about breast health screenings, and this is specifically for risk of hormone replacement therapy and the thermography. Is it legitimate or better?
Well, I'll answer the thermography question because I think that's easy. You know, thermography was such a cool idea. It just didn't, you know, the studies, this is why you do studies, it just didn't turn out. And the whole idea of thermography is to use heat to try and look to see whether or not you've got a cancer. They tried to use some of the same technology that was used for looking for cracks in luggage and the kind of things of the way they screen actually even at the airports. But it was a good idea, but it really turned out, I mean, if you had a cancer, there's a 50-50 chance that the thermography would identify it. And if you didn't, a 50-50 chance of it calling back. So it really, unfortunately, isn't better. In fact, it doesn't really add any value and it's not covered by insurance and you'd have to pay out of pocket. And I just don't advise it. I would think about how much money you would have been willing to spend for that and go spend it on yourself for something that you actually really want. That's how I would think about it. And what was the other question?
And it was specifically on hormone therapy?
Oh, hormone replacement therapy.
Yes.
You know, as a clinician who takes care of women, you know, again, I'm not someone who believes in one size fits all. There is no question that combined hormone replacement, estrogen and progesterone, so that's the Prem-Pro or the standard hormone replacement therapies, the longer you take it, you know, the more risk you incur. But, you know, if you have super low risk and you're really terrible hot flashes, you know, you probably can take it without worrying too much about it. So I think these are all the kinds of, this is why it's so important to know your risk. If you had really high risk, then wow, it would not be reasonable, you know, to think about it. And if you know, that's one of the things for us to also think about is if you're at risk for hormone negative cancer, does it matter? Well, that's a question we don't know, but that's a question we could potentially answer. So I think those are just arguments, again, for really trying to shift the way we think about screening and prevention. And, you know, we should really be thinking about this as breast health. How do we make sure that we do the best possible job in keeping you healthy? You know, screening enough, but not too much. You know, thinking, and if you're at high risk, really trying to think about prevention, like we do with heart disease. You know, we've been able to lower the risk of stroke and heart disease, like we've dropped it by 2/3. Why? Because we can identify people who are at risk because their blood pressure is uncontrolled, they have diabetes that's uncontrolled, or, you know, their cholesterol is high. And so we've actually developed all kinds of management plans around it. We need to do that for breast cancer. It's actually quite possible, but we have to have a concerted effort, build the risk models, which we've, you know, got a good start on, and make them improved. You know, we have some really effective prevention drugs for certain types, preventing certain types of cancer. These are things that we can start to put together. And we have a whole set of investigators really working on how to prevent the more aggressive cancer. That would be, I mean, fantastic. We're so excited about that idea. But, you know, this is why these kinds of studies are so important, because it's the first of many that will transform the way we think about breast health.
Okay, the next question is, does having an Ashkenazi Jewish ancestry factor in?
I can start with that. You guys can maybe add. The real reason we ask that question is that women with Jewish heritage have a higher risk than the average population of inheriting one of these common mutations, BRCA1 or BRCA2. And so, for example, the average, it may be only 0.5%, maybe only, you know, 1 out of 200 people would have this mutation in the average population. But in Ashkenazi Jewish women, that might be 4 times higher, like 2%. Again, it's not very high, but it's higher. And so because of that, we tend to ask that question, but it really is mostly not because the whole population is at risk for more cancers, but because there's a higher chance that you might be carrying one of these more these mutations. And so that's the real purpose of asking that question. And that's and sometimes, you know, part of the reason that's come up, and maybe Celia, you can comment on this, is that we've studied more of these populations. So you know, we know more about the Jewish population because they participated in studies. And this is why I want everyone to participate in studies. You know, there are actually common mutations in the Hispanic population. Some of them overlap with the mutations in the Ashkenazi Jewish populations because of at the time of the Inquisition, a large number of people migrated from Spain and went to Central America and South America. And so a lot of those populations are mixed and they share some of those same mutations. So the study of genetics is really about populations and how they've moved around the globe. So, but I think this is one of the things that we know is the more we know about different, you know, ethnic and racial groups, the better we can understand, you know, what risks to look for. Not because someone necessarily has it, but if they're more common, still we want to go and ask, do you have that? If you don't have it, you're not at risk. But if you do have it, there are things we can do to make sure that we can manage your risk a lot better. Celia?
No, yes, I think that there are some, they have found that certain mutations are more common in certain groups than others. Otherwise, we have a colleague at UCSF that found that certain changes were protective, and I think it's a colleague that is at University of Davis in Sacramento now. Her name is also Laura Fecherman. And so it's a question that it's known that Jewish women may have, there may be a higher incidence of BRCA1, BRCA2, and that's why we asked the question. And it is my understanding that it is factored, I don't know if it's factored into the risk scheme, it is factored in many breast cancer risk assessments that are in the web and so on and so forth.
Yeah. We don't need to ask that because we're directly getting the genetic testing information, which is actually better.
Exactly.
That makes sense. The next question, I think, is for Celia. Besides Spanish, are you planning to expand this resource in other languages sometime in the future?
I think we would hope to do that. There are many groups that unfortunately are underrepresented. I have to confess that it's a very costly endeavor to do translations. So we are moving slowly on that, but we are probably. I hope we do, and I hope that we do. There are lots of groups. I think that the second largest group will be Chinese.
Yeah, so Mandarin.
So, yeah, so my hope is that we do, but I don't know. I leave it.
So we're gonna put that to Allison.
We want to tell you the truth. We get together from the very beginning, how we can do it, how we can incorporate it.
Yes.
But it's an extremely expensive endeavor. So we're moving slowly, and we hope that we want to have more Spanish speakers. And I have to confess that we don't have as many as we wish. So please tell your Spanish speakers so to encourage us to move forward with other translations. Allison, I don't know if there are other plans.
Sorry.
No, I think that's the perfect answer. We would love to be able to do it. We will continue to evaluate what's feasible. But yes, right now it's just English and Spanish.
Let me ask you something. It's about 2:59 right now. Would it be okay to continue for about 5-10 more minutes? Because we have a lot of interesting questions. So will that be okay with everyone?
I think I can do that.
I think I can do that, yes.
And also just to note that with the questions that are coming in, they actually get saved as part of the webinar, so we can follow up with people after if your questions aren't answered. And please always feel free to reach out to us too at the info@wisdomstudy.org. We'd be happy to answer questions if you think of them later as well.
Has there been any thoughts to later include women that have been diagnosed and have completed their treatments? Maybe a health coach with recurrences.
Yes. Wisdom for Cancer. That's the program we call Wisdom for Cancer. I actually wanted to include that at the beginning of the study, but everyone talked us out of it because it's just too hard, too complicated. And it's sort of interesting that the whole impetus for doing the Wisdom study was to try and take what we've learned from the modern treatment of breast cancer and bring it into screening and prevention. And I think what happens is the prevention people do their work, the treatment people do their work, and the radiologists do their work, and there wasn't really enough crosstalk. And when I realized this, as being as someone who takes care of women with breast cancer, is that we weren't really reflecting all that we had learned in the last decade or two about breast cancer subtypes, and sort of thinking about it just didn't make any sense that hadn't gone into screening. And now we've really, in putting this whole program together and really bringing in the risk assessment, we realized that actually that way of looking at genetic risk ought to really help us think about how to screen someone after they've been diagnosed with breast cancer. That it's like full circle, bringing all that information together. So for example, if you had a cancer and say you were treated well for it, but you have your genetics say that you're at risk for developing, genetic cancers are more likely to develop cancer in the other breast, that actually could be really important in how we think about your screening or prevention strategy. So super important, and we're working hard on it. It just turns out to be even more complicated than this one.
And the next question might also make it a little complicated. Will there be a similar study in male breast health?
No, I don't think, well, I don't know is the answer. I think that right now breast cancer is 100 times more common in women, and that's what makes it worth screening. It's just, it's so infrequent in men that it just would not be reasonable or worthwhile. It would be a huge amount of resources for almost no gain. So the more we understand the risks for cancer development, especially the genetic risks, I think that is something that longer term we might be able to translate back. And maybe that would be part of an initial screening panel, that you understand as a person, what are those risks, and that could then determine how we go forward.
Okay. And how long is this study? And is this only for women in the US?
Good question.
Good question. So
Is it 5? How long do you ask people to participate, Allison? 5 years?
5 years, yeah. And we'll be recruiting for another 2 years at least. We keep trying to get more and more funding to extend it. And we'd love to keep in touch with people even longer than that. The minimum is 5 years, but just updating us long-term to understand who develops cancer, who doesn't. And I think importantly, going back to the last question, for those who do develop breast cancer, who are part of the Wisdom study, you do continue to be part of the study. We keep following you, but we don't give screening recommendations, obviously, since there's been a diagnosis. But it's really important to learn from those women who do develop cancer to understand what were the risk factors, how can we improve what we're doing, and so that's just another thing to keep in mind. As another question came up around, am I kicked out of the study? And the answer is no.
And not only that, we particularly want you to keep in touch. If you're in the study, we want to know, were you called back? Did you have a biopsy? And if you had a cancer, we want to learn about the type of cancer you have. And we're actually writing a grant right now to get the funds to be able to do a molecular profile. So these are tools that actually help give us information about your particular cancer that we can share back with you actually and your physician. So this becomes super important, because if we can answer the question, who is at risk for what kind of breast cancer, we can do so much better than we're doing today. So that becomes super important.
And I have a very interesting question here. Based on the results for the women who are at greater risk, what type of educational information are you sharing with them?
Yeah, that's a great question. So we developed this program called Breast Health Decisions. And again, we've worked really hard on this, and it's something to share with you to try and help you understand what your risk is relative to other women, and how that risk compares to other health threats you might have. And then we can talk about the type of risk you have and what different tools we might have to reduce your risk. Things that range from lifestyle changes, like controlling your diet and exercise, to things that you can do to, like if someone has a history of heart disease or they have high cholesterol, we would recommend that they take a statin, because that reduces the chance of getting a fatal heart attack or stroke by about 30%, so 1/3. So we do know that if you have a risk for developing breast cancer, you can drop that risk by about half by taking medications like tamoxifen. And importantly, we've now learned that we can use a much lower dose, which is, I think, much more appealing to women. And we have some tools now. We're developing the tools to be able to tell who's responding and who's not. And that becomes the key. So to making people feel comfortable taking medicines longer term. And there are certain risk factors you can't change. If you're 46 and you had your first child at 39, you can't go back and have a child at 26. If you didn't breastfeed, you didn't breastfeed. Those are things you can't change. We're really focused on the things that you can change.
Mm-hmm. Okay, there is a question here. It's kind of related. I had the density question. What will be the better follow-up? And then having a positive, even if false, why not follow up? Better safe than sorry.
Oh, this is just a follow-up to the density question. Yeah,
Mm-hmm.
and I think that again, you can certainly do that, and it depends on each individual. It's something that you can talk about with your provider. But one of the things that we feel strongly about is if you really are at high risk, then an MRI is the better test. And that's one of the things that we're looking for. So if you really are at high risk, I would use the MRI. And the ultrasound can be an adjunct. It's not that helpful. The great thing about ultrasound is really, if you feel a mass, it's great at evaluating where those masses are. If you see something on an MRI or a mammogram, if you can find it by ultrasound, it's much easier to manage and work up. So ultrasound is an integral part of how we kind of screen and look for. So if there's something that looks kind of funny on the mammogram, ultrasound is the next that's the next step, and it's great for that. That's where it really excels. But just as a scanning tool to look to see what's there, as I said before, it's not the best performer in a very dense breast tissue. But if you knew you were very high risk, then I would say we would want to recommend an MRI.
And now, what is the protocol for women who have implants? Can the 3D mammogram screening identify cancer?
Yeah, so it doesn't matter if you have implants or not, it's just the same screening. And there's big controversy about 3D mammography. A lot of places are just converting over to using it. But there's a big study going on to see whether it's better. And some people think it decreases the chance that you'll be called back for a false negative, but really the jury is still out. It's still being studied. The most important thing about getting a mammogram, if you can, is to go to a center that does mammograms where they have dedicated mammographers who are reading, that they are certified by MQSA, which is the certification system. And that, if you had a choice of going to a place where the general radiologists read the mammograms or a mammographer, someone dedicated and only doing breast, reads the mammograms, go to the place where there's only one person who's trained in breast radiology or breast imaging. And I would go definitely to that place because who reads your mammogram is probably the most important, both for finding cancers and not being called back unnecessarily.
Okay, now for women who have had a total hysterectomy, is the estradiol alone a high risk factor?
No.
Okay. Okay, I have a couple of more questions. So my mom currently has a HER2 plus breast cancer. I am in my early 30s, so I'm not yet qualified to participate. What is the best care routine that women in my age group can do since our age is considered low risk?
Be aware, be breast aware. So HER2 positive breast cancers tend not to be something that are driven by inherited factors. We don't quite know why, but that's generally true. I think that the breast cancer is just not common enough in women in their 30s to be screening everybody, and the breast tissue tends to be much denser, so it's not as good a tool, and so it just doesn't make sense as a population intervention. If you're at high risk, that's different, then you would get screened. But I think all women should know that if you develop a new mass, something that's new and different, and you're just aware of what your breasts feel like, that's something you want to bring to your provider's attention. You shouldn't be thinking, oh, I'm 35, there's no way I could get a breast cancer. We take care of a lot of young women because, we're a referral center, so a lot of people come in, but it's very common. People will tell me the story that they went in, they had a mass, and someone said, oh, well, you're too young, couldn't be breast cancer. So you are really the best person to know your breasts. Don't make it a giant deal. Get in the shower and kind of go up and down, take 10 seconds and just feel what your breasts feel like. And just get in the habit of once a month, at the beginning of the month, every month, same time, just, take 10 seconds to just go up and down on each side. And you're just looking for change. If all of a sudden you feel something that feels kind of like a rock that wasn't there before, go in and see your provider, because when you're young, the kinds of cancers you're more likely to get, you're not likely to get a cancer, but should you get one, it tends to be faster growing and they tend to be harder. So if you feel a mass, that's the most important thing. Don't ignore it. Go in and talk to your provider and get some imaging. That's the most important thing. And if it's definitely a new mass, don't take no for an answer.
Again, the last question, if I do not receive info that I am in a high risk group, can I assume that I am in a lesser risk group?
So Alison, why don't you take that, because that's really about how the information is provided back to you.
Yeah, so we give screening recommendation letters as part of what we provide back to the participants in our portal. So we will tell you when you should get your next mammogram based on when the last one was that you've had. So for those that are in the higher risk group, they'll also get a direct outreach from a breast health specialist. For those that are in the lower risk groups, we'll note that on the screening recommendation letter, and your assignment as in terms of when you should get your next mammogram, maybe to come back every 2 years as opposed to every year or more frequently. And if you're in your 40s, it may be that you can safely wait until you're later in your 40s or even 50 to get your next mammogram. So in that letter, we'll indicate based on your risk when you should go back for your next mammogram.
Yeah.
Okay.
And again,
And I think we got
anyone's in the study and has any question, info@wisdomstudy.org, or you can reach out to any of us at any time.
And I know we got some good comments also during the chat. And I know since it's being recorded, you guys can probably answer those questions separately. But thank you, everyone. And thank you to the speakers. Thank you to Celia and Laura. That was a great conversation.
Mucho gusto a todos.
Thank you for all the participants.
Exactly.
Wonderful
questions
actually.
Really
Great
fantastic.
questions. Thanks, everybody.
We hope you'll all sign up, tell all your friends and tell everyone you know. And if you're excited about this and want to be an ambassador and sort of spread the word, please call us. We'd love to have you join us. Remember, only way to do better is to know better. And the only way to make sure that this information applies to you is to make sure that you participate and are part of the way we move the field forward. So we're so excited to have the opportunity. Marcela, thank you so much for inviting us.
Thank
you for this joint work. And if anybody has any questions too about the work that we do at the Alliance, feel free to contact me directly. My email is mgaitan@healthamericas.org. And I'll be happy to also provide any information you guys have about the Wisdom study as well.
Thank you, guys.
Thank you, everyone.
Thank you
Have
so
a good
much.
day.
Have a good afternoon.
Bye.
Bye.
Bye.